It's a 30-degree called angle, so you would do that first. And each slash mark, if you remember, is 15 degrees. So we're going to go to 60. And you want to be, right at. You want to be right at. All right. When you set your patient down on this board here, you want to go quite low. Because when you go to adjust, if you need to adjust tube and bucky when you're done, you want to adjust up, not down. Because going back down will mess with your patient's head position. All right, when you sit down, you want your patient to be away from here, right? You want to set them on the chair, they can hang on to this, and you want to tell them, look down, put your chin close to your chest, lean back, and put the back of your head on the board. So that's kind of how you want to start out. So that's why we have this space here. All right. And just a minute. There we go. All right, so we're going to start. Let's go ahead and have a seat here. You're going to be facing the camera, as I like to say. All right, now as soon as we get our patient's back of the head on the board, we're going to line up the OML to be perpendicular. So I do want you to come up here, some on this side, some on this side, so you can see what we're doing here. All right, you're going to move down and then lean back, put the back of your head on the board. There we go. So now the first thing we're going to do is line up the OML, the orbital meatal line. There's the outer canthus, there's the EAM. It's right on. Right on. Somehow she knew exactly where to go. So the OML is lined up, it's perpendicular. And then we would need to be 2.5 inches above glabella. Now she is pretty mid-sag. I should have made sure she was first. I mean, I'm just lucky that she was. But normally that's what you want to do. Set your patient, get in mid-sag, pretty much. All right, 2.5 inches above glabella, I'd say that's pretty good. So my adjusting is just up, which is that's the way you want to go. All right, and now make sure you remain mid-sag. Move you just a little bit. And then no rotation. So take your fingers and put them on the board and bring them in. And try to feel rotation and try to take it off. All right, so we're good with this one. This is our AP Axio Town. And you can relax. But let's just say, don't relax too much. Let's just say, and a lot of people can't get OML perpendicular. Let's just say she can't do it. So then what you're going to do is lift up. Then you're going to get the eye OML perpendicular. And you're going to increase the tube angle by 7 degrees. 7 degrees more caudal. Because remember, there's a 7-degree difference between the OML and the eye OML. So, all right, but now our next x-ray, and you and I are going to switch again. It's called the SMV. Perpendicular center ray. Drop this down. But SMV. It's called the submental vertical projection. Submental, because here's the mentum, the chin, right? We're going to go in underneath it. We're going to exit the vertex of the head. So submental vertical projection, Schuler method. So now I like a chair like this, because for me this works good. But I think a lot of people need some support back here. So this is how we'll do it. We'll put the back of the chair to their back. All right, but what you're going to tell the patient is we're going to put the top of your head on the board. So what I want you to do is look up, lean back, and put the top of your head on the board. All right, and then as soon as they do that, and this can be hard on your neck, so if any of you have neck problems, let me know, because we will not have you do this, okay? All right, so, okay then, let's get you down there. And the first thing you do is line up the eye OML. The eye OML should be now parallel. Okay, so good with that. Put the top of your head on the board. Oops. That's not even close. There we go. I'm lining up the eye OML. Let's have you look up just a little. No, the other way. Oh, come down back. More, Kaylin, I'm sorry. Are you okay?
Mm-hmm.
Okay, OML is now parallel to the image receptor. Again, I should have made sure she was mid-sag first. Okay, but center ray is 3/4 of an inch anterior to the EAM. And now I'm going to move you just a little bit. I hate doing it afterwards. There we go. 3/4 of an inch anterior to EAM, entering mid-sag. And do you see the nose? That's the shadow we want. Now this is going to move. I got to realign to the Bucky. And then again, adjust, make sure your patient is truly mid-sag and make sure there's no rotation on your patient. All right, and this lets you relax, because that's hard. Are you okay?
Yeah.
All right. And if you're doing this, you too, if it hurts, makes you uncomfortable, just let me know, or whoever is positioning you, and we'll get you out of that position. All right, so that's the S&V shooter method. By the way, the first one we did, the AP Tau, is for the occipital. This one is for the base of the skull structures. Now, one of the goals here with this one is that you are taking this into ray and directing it right to the cella turcica. So that way, 3/4 of an inch anterior to the EAM, that's important. All right, so now let's have you turn around and face the board, and you can put this to that side again. All right, so 15 degree, this is a 15-degree caudal angle. And, okay, let's have you scoot way, way up. And you're gonna have to straddle that, because otherwise we can't get you close enough. You come up, yep, really close even. Yep, all right, and now what I want you to do is look down, put your nose and forehead on the board, oops. And now we're gonna line up the OML to be perpendicular. And look, it is perfectly there. Actually, look up only just a little. Okay. Look down again. There we go. All right, OML perpendicular to the image receptor. Center ray exits the nasion. All right, exiting the nasion. This is going to come up underneath your forehead. All right. Okay, I'm going to move you this way. You want to be mid-sag. Now sometimes you can look at the neck too, to make sure you're mid-sag. Then take off any rotation, and marker on, and we're good to go. So PA axial Caldwell done. This is for the frontal bone. You can relax from that. And now we would do both laterals, but I'm just going to do one. The one thing you remember here, with the skull, we want to switch this to crosswise now. All right. So we want to get it. Let's actually put this on that side. Oh, sorry.
No, you're fine.
Yeah, go ahead and sit down. And you're going to be facing the board. All right. Actually, I'm going to get in there. Sorry, Kaylin. All right. So, when you're trying to get a lateral x-ray of your patient, this leg and this shoulder has got to go back. And you want your patient sitting up. I mean, if they're back here, it's really hard to get a lateral, right? But if you can set them upright and scoot them in, get this leg back here, get this arm back, and then have them come in like this, is so much easier to get your true lateral. All right, let's get you in there. put your hips even closer. There we go. Set real straight. And then bring this arm out this way. Look towards me and put the side of your head and come this way. A little bit more. Now, I'm just trying to get this a little bit closer to the EAM. Wow, we're really. Okay, come forward. All right, because eventually we're going to be 2 inches above EAM, but why not just start right there? All right, now get a true lateral. All right, so interpupillary line needs to be perpendicular, mid-sagittal plane needs to be parallel. Now, she's got rotation in her mid-sagittal plane, right? It's coming in this way just a little, so we got to make it parallel. So what I'm going to do is have you bring your shoulder out, look out this way just a little bit more, tuck down, because I know that. And now, see the chin? Can we bring the chin in? There we go. So that brought the interpupillary line perpendicular and mid-sagittal plane parallel. So we have our true lateral. But one more thing is very important on the lateral. IOL needs to be parallel to the transverse axis of the image receptor. So take this down to the level of the EAM and line up the IOL, which it really almost is. Look down only a little bit. There we go. IOL is lined up. And now, let's bring you forward. We need to be 2 inches above EAM. 2 inches above EAM. We got light beyond the frontal bone, above the vertex, behind that occipital bone, so that is all good. That's all what we want. And so our lateral, one of our laterals is set. You can relax. All right, and then of course we would need, this is for the right parietal bone, and then we would need to do a ladder for the left parietal bone. So that's our projections. Okay, we'll get you out of there.